Good afternoon, everyone, and welcome to our today's session. Our title for today is Pesticide Toxicology and the Management of Poisoning, where we're looking at the poisoning treatment toolbox. And our speaker is going to be Dr. Elisa Lockwood, who is an emergency medicine physician and medical toxicologist. She's the medical affairs lead as well, and a senior science fellow at Biocrop Science. So without much ado, I want to welcome Dr. Lockwood to be able to start us off and share the slides. Welcome, Dr. Lockwood.
Thank you, Dr. Mule. Very, very nice to meet you. Welcome, everybody. I'm looking forward to our discussion today. I'm just going to get started by sharing my screen. And put it in. There you go. Can everybody see the screen okay? Because I can't see you.
Yes, we can see you. We can see it.
Excellent. Wonderful. Okay. So I'm Dr. S. Liza Lockwood. I'm an emergency physician and a medical toxicologist, and we are going to do part 3 of our series today and talk about the management of different kinds of exposures. Now, these are going to be in particularly overdose kind of exposures where there's been a suicidal ingestion. But before we get started with that, what we're going to do is we're going to talk about a little bit of sort of covering some of the basics pathophysiology as a reminder of how things work to set up the rest of the talk. So to review the nervous system in general, the motor nervous system in general, you'll remember that there is the autonomic nervous system and the somatic nervous system. And with the autonomic nervous system, that's your involuntary muscles that help you do a variety of things that you need for survival. And then your somatic motor pathway is your voluntary pathway. So you think, I want to move my arm, and you are able to move your arm because of a signal that goes from the brain down the nerves and then acts at the neuromuscular junction. The autonomic nervous system is divided into really 2 big categories, the parasympathetic system and the sympathetic system. And those are going to come into play when we talk about organophosphates and carbamates and things like that. For the parasympathetic pathway, you will get a signal coming from the central nervous system that travels down the axon of the nerve. You'll get acetylcholine released from the presynaptic terminal onto a nicotinic receptor in the ganglion, and then at the postsynaptic terminal will then release acetylcholine again onto a muscarinic receptor in your smooth and cardiac muscles. It does land on some exocrine and endocrine glands too, and some adipose tissue. For the sympathetic nervous system, you will have a similar kind of setup where you will have a signal from the central nervous system down to a nicotinic receptor. The presynaptic terminal will release acetylcholine. It will land on a nicotinic receptor and then send down another signal, a norepinephrine or epinephrine, which will land on an alpha or beta 1 or beta 2 receptor. Those are the big things to think about when you're talking about the various motor systems that you need for life. So now let's talk about how this kind of applies in the real world. In the real world, the really important part is your parasympathetic nervous system. You need to be able to rest and digest to survive. So the parasympathetic nervous system is geared to doing those kinds of things. The sympathetic nervous system, you need to run away from a dinosaur. So when you think about these things, I want you to think about everything that happens to you when you're running away from a dinosaur. Your eyes dilate, your heart rate goes up, your blood pressure goes up, all of the things that you need for this immediate survival kick in. So let's go ahead and talk about how these play into exposures with these two classes of chemistry, so organophosphates and carbamates. So let's go back into a little bit of history, and I showed this in a previous in our day 1 lecture, but for anyone who hasn't seen this, the earliest use of cholinesterase inhibitors were recorded in West Africa. The ordeal bean is the Calabar bean, and it's named for the Calabar River in the Gulf of Guinea. And an explorer by the name of Dr. Daniel went and looked at people who were doing a sort of people who were accused of a crime. If they would be fed this Calabar bean, they would have what we call a cholinergic toxidrome. And they would have nausea, vomiting, diarrhea, and a whole bunch of untoward effects. And if they ate the bean and had those effects, they were presumed guilty of the crime. And so that was it, but people had such respect for this particular test that they wound up often volunteering to demonstrate their innocence, and they would get very sick afterwards. Well, it turns out that the Calabar bean has a chemical in it called physostigmine, which we use in medicine all of the time. We'll get into that a little bit. But when people get an overdose of physostigmine blocks the enzyme that's responsible for the breakdown of acetylcholine. So you wind up having too much acetylcholine at all those neuromuscular junctions for the cholinergic nervous system. So we've adapted this natural kind of plant to a whole variety of different products. So there are 2 classes of agents that block cholinesterase. And when it blocks cholinesterase, it makes too much acetylcholine float around in various different sites in the autonomic nervous system. And there's a cascade of events that happens after that. But the 2 class of agents are organophosphates and carbamates. So an example of organophosphates are malathion, parathion, mitriphenate, which are pesticides. But it also turns out that mitriphenate is used medicinally and was actually on the World Health Organization's list of essential medicines to treat schistosomiase hematobium in around Africa. And it's only been recently replaced with praziquantel, but this is a backup in case there is a development of resistance in the schistosomiasis organism. Carbamates, when we'll get into the difference kind of in general, carbamates are also used as pesticides, but there are other classes of medicinal use too. So as we mentioned before, physostigmine is used to reverse a anticholinergic toxidrome, and we can talk about that in a bit. Pyridostigmine is critical for the management of myasthenia gravis. In the disease myasthenia gravis, you have antibodies that react to the nicotinic receptors at the neuromuscular junction of the somatic nervous system. They are competing for that receptor with acetylcholine. And so if they block that receptor, you wind up getting weakness. And the reason why you use pyridostigmine to treat this is because it blocks acetylcholinesterase and at the neuromuscular junction lets more acetylcholine float around. It is not available to break it down. And because it's not available to break it down, the acetylcholine can compete with the antibodies and decrease the weakness. Neostigmine is also used to reverse paralysis in general anesthesia. So these are not only just the chemicals that you use for insecticides, but they're also able to be the class of chemicals, not the same chemicals themselves, but the class of chemicals are able to be used medicinally as well. And so the normal physiology of this whole event is acetylcholine. This you can see my arrow here, acetylcholine is released from the presynaptic terminal and binds to receptors on the postsynaptic terminal. And the remainder of the acetylcholine is broken down by acetylcholinesterase in the synaptic cleft. The pathophysiology is if a cholinesterase binds to acetylcholinesterase, to that enzyme, it prevents the breakdown of acetylcholine. And then the postsynaptic receptor is repeatedly stimulated by excess acetylcholine. So organophosphates bind to acetylcholinesterase and undergo something called aging, at which point they become irreversibly bound to that enzyme. And so if they're irreversibly bound, you have to make that enzyme again for it to function. So that takes a little bit of a while. Carbamates, on the other hand, bind to acetylcholinesterase, but they spontaneously hydrolyze. So they break up and you can have the enzyme be reactivated. Esterase inhibition occurs faster with carbamates, in less than 5 minutes at high doses than in organophosphate poisoning, and will last a shorter time as it's reversible, 1 hour to symptoms and 1 hour to recovery. It depends on the carbamate, but these can be fatal in very short times. So remember, we have the parasympathetic nervous system, right? So we're going to go through what happens to you if there's excess acetylcholine floating around in that synapse. So first of all, on the parasympathetic side, you get muscarinic effects. So these muscarinic receptors repeatedly stimulated. And when you think about resting and relaxing in normal cases, and you're eating, you'll salivate, and your gut digests, and you have peristalsis. All of that goes on to overdrive. So you have salivation, you have lacrimation, you have urination, you have diarrhea and GI distress and emesis. So you're basically having fluids come out of everywhere. So, but nobody's ever lacrimated themselves to death. So what really harms the people who've overdosed on these chemicals? The killer bees. So bradycardia, bronchorrhea, and bronchospasm, they literally start having lots of fluid build up in their lungs, and they wind up having drowning in their own secretions. So this is the part that gets the people in trouble. The nicotinic effects. Now remember that the nicotinic receptors are on your autonomic ganglia from the presynaptic terminal, and they're also at the neuromuscular junction. So you can get diaphoresis. So you can actually stimulate the sympathetic side, because that's acetylcholine's in the presynaptic terminal on the sympathetic side as well. So you may get a paradoxical diaphoresis, mydriasis, dilated pupils, tachycardia, and hypertension. So it just depends on the balance of parasympathetic or sympathetic. For testing purposes, the parasympathetic effects are predominant. So you usually see pinpoint pupils, but occasionally, because of overstimulation of the presynaptic terminal from the sympathetic side, you can occasionally get dilated pupils. And then at the neuromuscular junction, you wind up with fasciculations and paralysis. So what happens is that the acetylcholine continuously stimulates the neuromuscular junction and lets in sodium into the muscle cells. And sodium is positively charged, so it causes a cascade of effects where you get calcium-mediated calcium release from the sarcoplasmic reticulum, and then you get fasciculations and paralysis. In the central nervous system, you can wind up with so much acetylcholine that you get delirious and confused, and you can have coma and seizures. What about testing? So testing, you can get testing, but you can pretty much diagnose this from the bedside. So it's not really necessary to get laboratory tests, but if you want to, acetylcholinesterases in red blood cells are the most reliable test to do. But the reagents aren't particularly available. There's an automatic device on the market, but it's very expensive and it can't be made available in all hospitals. Transport to lab centers can often delay diagnosis and treatment assessment. Once again, this is a bedside diagnosis with a very classic toxidrome, a cholinergic toxidrome associated with it. So you really don't need a blood test. It is, and then your levels in your red blood cells of acetylcholinesterase is genetically determined, so it doesn't change very easily. If you are monitoring this as part of an occupational medicine program, a 30% drop of individual activity is highly alarming for a worker, but that would mean that you would have the baseline that worker had. So if you don't have the baseline, it's not that useful to get this test. Butyrylcholinesterases are easy to determine. They're single tests that are becoming available. It's synthesized continuously in the liver, but it's prone to changes due to liver issues and medications. As a surrogate, 30% drop from normal values can also be used to decide upon therapy with typical symptoms. I would actually probably not bother with either one of these tests. So in patients who've ingested these insecticides, decontamination is really critical. Clothing should be removed and discarded. Ocular exposures require thorough irrigation, and dermal exposures may be cleaned up by using a dilute hypochlorite solution. I don't know if how many of you were here for the very first talk I did, but I mentioned that there was a patient that one of my colleagues took care of who had a malathion overdose, who was a farm worker in Indiana. And he drank a whole bunch of malathion, and there were problems because he was put in an enclosed space when he was not adequately decontaminated. So he was put on a helicopter to get evacuated to a hospital with higher care, and was off gassing from his organophosphate ingestion into the helicopter. And when he did that, the pilot's pupils started to get a little bit constricted, which you don't want to have to happen to a pilot, right? And the healthcare workers started to feel nauseous and dizzy and things like that. So you really want to make sure that you decontaminate these people in the pre-hospital setting. You absolutely want to avoid mouth-to-mouth resuscitation in these patients. Now, remember, most people aren't going to put their mouths on people who've had lots of vomiting and secretions coming out. But that said, that vomit is going to have organophosphate in it, and it's going to off-gas. So you want to be careful with that. Adequate decontamination should, again, be taken care of prior to loading the patient into an enclosed space. Healthcare providers should gown and glove while handling these patients. Many of these agents can penetrate latex and vinyl since they're very lipophilic. Therefore, you really want to use nitrile or neoprene gloves. Leather can also act as a reservoir for these agents and cannot be decontaminated. So you want to discard leather that is like belts and things like that if it's soaked in these agents. So what do we do for management once we've decontaminated these folks? So you want to do airway, breathing, and circulation. Often the patient is in severe respiratory distress and needs to be intubated. If you are intubating, if you're in anesthesia and you're intubating these patients, you want to avoid using the medication succinylcholine or dexamethasone, because that's broken down by acetylcholinesterase. So it will have a prolonged paralytic effect rather than the regular 4 minutes. So you want to be very careful with that particular drug when you're intubating these patients. Once IV access is obtained, then you want to consider about OG lavage. And remember, when you are doing oral gastric lavage, that lavage fluid vomit can be a hazardous. So you need to be careful about that. So once again, decontamination, you want to protect the personnel by using neoprene or nitrile gloves, long sleeve clothing. If needed, you can use a Tyvek suit and a filter mask. Skin and eye decontamination, you want to have ample and repeated water and soap protection of personnel. You want to flush the eyes out. Then you want, if you're going to do gastric lavage, you want to intubate the patient, and you really want to only kind of consider this this avenue of treatment only during the first hour after ingestion, because by the time it's beyond an hour, most of this is going to be absorbed. I think activated charcoal is probably not that beneficial in these cases, and I would absolutely not give cathartics. And the reason why, well, if you think about this, they're kind of decontaminating themselves. They're having nausea, vomiting, and diarrhea. So that a cathartic's just going to make that diarrhea even worse. So I wouldn't do that. And they're with the vis-a-vis the gastric lavages, they're vomiting it up. You probably don't need to do that. I showed this slide a couple of weeks ago as well. And it's very interesting that Mother Nature has produced two plants that actually reverse the effects of each other. The discovery of a plant that produces a carbamate, the carbamate cholinesterase inhibitor on the left is once again the calabar bean, right? And then this plant on the right, datura, also it makes hyoscyamine, scopolamine, and atropine. And so that's really kind of interesting that Mother Nature has these effects. So what is the antidote? Well, the antidote comes from this plant, and it's called belladonna, and it is the source where people get atropine. So why is it called belladonna? In the Middle Ages, belladonna is Italian for beautiful woman. In the Middle Ages, Italian women thought it was attractive to have widely dilated pupils and would drop extracts from this plant in their eyes. Apparently, it was more important to be beautiful than to be able to see. Anyway, the nightshade family of plants is where atropine comes from. And atropine, the drug atropine, was named for the Greek mythological character Atropos. And she was the eldest of the three fates and was known as the inflexible one. In Greek mythology, her sister Clotho spun the thread of life, and Lachesis measured the length of life. And it was Atropos who chose the manner of death and ended the life of mortals by cutting their thread. So as a medication, this is life-saving in these cases. However, if you ingest these plants or ingest the datura that I showed you in the plant before, you can have a florid anticholinergic toxidrome that we can talk about in another case. So what's the antidote? Atropine, which comes from those plants, is the antidote. And you want to use this therapy only if they're clear symptoms, as we talked about a cholinergic toxidrome. If you've managed to follow their serum cholinesterase levels previously, you can use atropine in those cases too, below 30% of normal. That would make you use it. Now, atropine is really the most important treatment for this. And you want to, in normal cases, when you're dealing with a cardiac arrest or a bradycardia, you really don't want to do too much atropine because you can give people this florid anticholinergic toxidrome. They can get delirious, they can get wild, all sorts of stuff like that. But in this case, you want to titrate your atropine to the cholinergic symptoms, especially the respiratory symptoms. So if they're having pulmonary edema and frothing at the mouth because of pulmonary edema from pulmonary secretions, you want to be very aggressive with your atropine treatment. So you want to give 2 milligrams IV, and then if the symptoms persist, 4 milligrams on top of that. If symptoms persist, 8 milligrams. So you want to double your doses every 5 minutes and then switch to an infusion. Children, you can see that there's a 0.1 mg per kg body weight is with careful repetition of the dose, depending on the reversal of symptoms. Now, previously, there has, in cases like this, the whole hospital has been depleted of atropine for one patient. So these people can get very, very sick and require lots and lots and lots of this. And once again, you don't need to titrate it to their heart rate. People get concerned, oh, they're getting tachycardic with this. You don't need to titrate it to that. You need to titrate it to their pulmonary secretions, is what you need to do. So for organophosphates, you may consider using pralidoxime if you have it. What pralidoxime does is it actually goes to the enzyme, acetylcholinesterase, and knocks the organophosphate off of that enzyme and regenerates it. So you can reactivate that cholinesterase effect and then break down the excess acetylcholine again. The problem with pralidoxime is it's really not available in all countries, and if so, it's only available in large hospitals. And it's got sort of mixed results as to whether or not it's that beneficial. If the organophosphate has undergone aging, that means it will be permanently bound, covalently bound to the acetylcholinesterase, and you will not be able to reverse that with pralidoxime. So you want to get it into before the aging starts. So in adults, you can bolus it 40 mg per kg or 2 grams over 30 minutes. And then you can put them on an infusion as needed. In kids, you want to do 20 to 40 mg per kg over 30 minutes. And then if you needed, you can put them on a confusion or on an infusion. One of the common features that you see in organophosphate overdoses is seizures. And so you'll use your regular seizure protocols with a benzodiazepine to stop seizing. And that's pretty standard. And then you want to do really intensive supportive care. So if they're hypotensive, you give them fluids. You want to be cautious a little bit about it because you want to make sure that you're not overdoing pulmonary edema, but respond to the vital signs and do intensive supportive care. Patients may die from these overdoses despite adequate treatment. All right. There's a really interesting phenomenon that you sometimes come across in patients who seem to have recovered somewhere 2 to 7 days after the poisoning. And it's called intermediate syndrome. And intermediate syndrome, they'll seem to have improved. And then all of a sudden they'll have generalized weakness and especially weakness of their neck flexor. So they have a hard time keeping their neck extended, and so their necks get weak, and then you'll start seeing decreased ventilatory capacity. So they start having trouble breathing, and this is due to muscle weakness. You may have to re-intubate them and mechanically ventilate them for 1 or 2 weeks again. And there's no specific treatment for intermediate syndrome, but it's something to watch out for after the poisoning within a week. Carbamate intoxication is very similar from the atropine perspective, very similar to treatment of organophosphates. Carbamates, however, do not age. They do not become irreversibly bound to acetylcholinesterase, and that's why you would not use pralidoxime in this case. So otherwise, it's very, very similar in terms of the atropine. You can use this particular poster to run through what it looks like, what these poisonings look like, and how to treat them. So once again, pinpoint pupils, reduced heart rate, bradycardia, oozing of sweat, muscle twitching, incontinence, secretions, emesis, nausea, and you want to treat them symptomatically. You want to rinse them off, evaluate for the severity of symptoms. Your antidote is atropine, and you want to get them to a higher level of a hospital. So those are the big takeaways from these particular overdoses. And here are some sources that you can refer to if you have any questions. You can look these up. Okay, moving on to another class of chemicals, and these are organochlorines. And once again, these are insecticides. So carbamates and organophosphates are insecticides. And so what they do, and organochlorines are too, what they do, so what the organophosphates and carbamates do is they paralyze insects and make the insects die because they paralyze insects, because insects also have acetylcholine in them. Organochlorines are another class of insecticide. Meet the #1 killer of people on the planet, the mosquito. And the mosquito has caused so much death and destruction that there's always been a long interest in controlling mosquitoes, not only because they're a nuisance and cause itchiness, but as you all know, they transmit malaria, dengue, chikungunya, and a multitude of other insect-borne illnesses that have had a very high mortality. So the first prototype organochlorine was dichlorodiphenyl trichloroethane. It was first synthesized in 1884 and forgotten about. It was put on a shelf. Its insecticidal properties were discovered by a Dr. Paul Mueller in 1939, which was very timely as there was a huge shortage of pyrethroid insecticides. And we talked about pyrethroids last week. Derived insecticides and large outbreaks of insect-borne illness in the troops as they were entering into World War II. As I mentioned in a previous lecture, the leading cause of death in the military is actually not war wounds, but it's insect-borne illness. And so this becomes a very big deal for leaders and generals in the military. In 1948, Dr. Mueller won a Nobel Prize for his discovery, and by 1953, DDT was credited with saving 500 million lives and averting a billion insect-borne illnesses. At that same year, there were 18 cases of malaria in Sri Lanka, and DDT is credited with having eradicated malaria in the United States and Europe. Now, obviously, because it was a broad spectrum chemical and it bioaccumulated up the food chain, it led to worldwide bans, but it is still used in some malaria endemic countries because it's got some still good insecticidal properties, especially when Plasmodium falciparum is bad. So many of these have been banned. So today, really only diclofol and endosulfan are around. And then for lice treatment, people sometimes use lindane. Some countries, not Kenya, still have DDT listed. And that's often for surface treatment against mosquitoes. They're painted on the walls. Not only does it have insecticidal properties, but it's also got repellent properties. So the mosquitoes don't want to land on the walls. The issue with organochlorines is not so much that they have acute toxicity, it's their tendency to get deposited in fat tissue and then have a very long half-life. So it builds up in tissues and it also persists in the environment. And for diclofol and endosulfan, that's a little bit less. In Kenya, there's only one case report of overdose, and then, or I guess maybe that might be globally actually. And then for endosulfan, there are plenty case reports of it. So the fatality rate of severe endosulfan poisoning has been reported to be fairly high, 30 to 40%. So DDT, back to DDT as sort of the prototype, how does it cause toxicity? It causes voltage-dependent sodium channels to remain open. And then some organochlorines inhibit the GABA receptor. Now, if you remember, GABA is the main inhibitory neurotransmitter in your brain. And so if you have a lot of GABA floating around, you get sleepy. But if you inhibit the effects of GABA, now you have unopposed excitatory tone in the brain, so you can wind up having seizures. So the organochlorine insecticide that is registered in Kenya is diclofol. And for diclofol, there's only one case detailing signs and symptoms, and the patient had nausea, dizziness, vomiting, confusion, and lethargy that resolved in about 3 weeks. So these are the signs and symptoms that you'll see. You'll see maybe if they are hypotensive, you can maybe get some liver and kidney dysfunction. With muscles, because of this excess excitatory tone, you can get some rhabdomyolysis. You can get hypotension, tachycardia, QT prolongation, some respiratory distress. The more characteristic features are seizures and convulsions. That should sort of tip you in that direction. And then if you want to do laboratory testing, they may have a metabolic acidosis, obviously, because when you're breaking down all that muscle or you're having seizures, that can lead to that. leukocytosis. You can have an elevated creatinine due to kidney damage. You can have an elevated ALT due to liver damage, glucose, and then myoglobin can be up. So these are the kind of non-specific signs that you can have. This is not going to be a florid toxidrome like the organophosphates or the carbamates. You're going to have far more nausea, vomiting, diarrhea, and pulmonary edema with those than you will with organochlorines. So how do you treat these patients? You want to do thorough skin decontamination with soap and water. And once again, if it's in their eyes, flush their eyes thoroughly. Generally speaking, if it may be difficult to get to these patients in 1 to 2 hours. If you're out in the field with the patient, and it's only shortly after ingestion, you may want to get them to vomit. But really, there's not a lot of evidence to suggest that that's going to be all that helpful. In case of ingestion, you can do a gastric lavage, and you can in these cases give them activated charcoal and magnesium sulfate. They should be monitored for several days in the upper level care to make sure that they don't deteriorate. And once again, typical treatment for seizures. So benzodiazepines, you can give phenobarb, even effective orally. And if that's not successful, you may want to consider propofol, because one of the things that propofol does is not only does it enhance GABA tone, so it enhances the effects of GABA. GABA will act on a receptor in the brain, the GABA receptor in the brain. It will open up a chloride channel. Chloride is negatively charged, so it will hyperpolarize the cells in the brain and make it relax. But propofol also will block the effects of glutamate, which is the main excitatory neurotransmitter in the brain. It opens up it acts on the NMDA receptor and opens up a calcium and sodium channel, and that's excitatory. So if you get too much glutamate activity, you can wind up having positive charge in the cell, excites the brain, right? So if you want to turn that off, propofol has both those effects. So it really helps with the seizures. They can get hypotensive on propofol as well, though. So you've got to be careful with their blood pressure. So a dose of more than 35 grams of endosulfan is regarded as a predictor of a risk of mortality. Okay, so that's organochlorines. Here are some sources for you to look up if you have any questions about that. Let's move on to chlorphenoxy herbicides. Chlorphenoxy herbicides are really interesting. They were discovered in the 40s, and they were doing research on to see what would impact crops if chlorphenoxy herbicides would have a negative impact on crops. And they realized when they were doing this research that it affected broadleaf plants like the weeds, but it didn't affect grasses. And why is that important? Well, the reason why that's important is because maize is a grass. So now you have a chemistry that can affect weeds, and the grasses are resistant to it. So you can grow your maize and have less weed pressure. Now, why is that important? Well, because weeds steal light and nutrients and overgrow in fields, and they can be toxic. If you get a toxic weed in your food supply, you can get into pretty much trouble. So it was very interesting. And so the other people who got very excited about this finding were people who manage golf courses, because all of a sudden you had nice grass on your golf course, but you didn't have these broadleaf weeds. So grasses are monocots and are more resistant to these chemicals because they're able to metabolize them more efficiently. And the way they work is really interesting as well. They work by stimulating the rapid growth of the plant until it outstrips its nutrient supply and then begins to curl. These have very low toxicity for animals, since they don't rely on these particular growth hormones, auxins. It's called auxins. People and animals don't rely on those for growth, but plants do. And so this helps that it makes them outstrip their food supply. So it's very low toxicity and exposure. If you have a big ingestion, an ingestion can cause toxicity. So as these substances are acids, a significant ingestion will lead to a metabolic acidosis. Okay, and so you can have EKG alterations, myotonia, muscle weakness, and elevated myoglobin. And with that, you can wind up having elevated creatinine in the blood and CK elevated in the blood, indicating muscle injury. But that can lead to renal injury with an elevated creatinine as myoglobin builds up in the kidneys. Also, they're weak uncouplers of oxidative phosphorylation. So we can talk a little bit about oxidative phosphorylation, and we'll get to that in a future pesticide. But oxidative phosphorylation happens in the electron transport chain in the mitochondria, and it's responsible for making ATP. If you uncouple that gradient, what you do is you don't make ATP as efficiently. And remember, ATP is the energy that makes your cells move. Without ATP, we can't do anything. But if it's uncoupled, it's released as heat. So you can have a fever with these. So hyperthermia from production of body heat. However, most cases are minimal poisonings with only mild gastrointestinal symptoms. They have nausea, abdominal pain, and headaches. Weakness and dizziness have been reported, but overall, these are very low toxicity chemistries. There's good absorption through the oral route, and as we talked about previously, very limited absorption through inhalation or dermal, your skin. Okay, so what are the chlorphenoxy herbicides registered in Kenya? 2,4-D, dicamba, MCPA, MCPP, and those are the big ones. Okay, so if you get exposed to big doses of it, you can maybe get a little skin irritation, very rarely some skin depigmentation. For the GI tract, if you drink it, you can get irritation, abdominal pain, diarrhea, and nausea. Some of that can be due to the formulation, too, the other ingredients that are mixed there. The other ingredients aren't usually toxic in and of themselves. They can sometimes cause corrosive injury. And if they're in a solvent, like in a solvent, and you get inhalational injury because somebody's vomiting and then aspirates, you can get some direct injury to the lungs that way. But most of the time, it's really you don't need to worry so much other than the local effects of the formulation. You can get some muscle injury with it at very high doses, and at very high doses, metabolic acidosis with EKG changes, tachycardia, arrhythmia, kidney failure, electrolyte disbalance, and multi-organ failure. And in the central nervous system, every once in a while, hyperthermia convulsions, but the vast majority of the time, this is not it. Interestingly enough, a more recent paper reports a loss of the taste of sweet, inhibition of a taste receptor. That can be kind of a bedside clinical test that might serve as a diagnostic sign. Okay, and then once again, you want to decontaminate these patients, wash and shower the skin with water and soap, irrigate eyes thoroughly. As substantial amounts of this will start making people vomit, you really don't necessarily need to make the vomit. I tend to stay away from trying to make people vomit just in general, especially because some of these can be corrosive. And then gastric lavage, not needed, only in life-threatening amounts ingested in the first 60 minutes. There's no antidote for most of these poisonings. Treatment is supportive. And once again, aggressive supportive care is needed if it's a bad overdose. Again, most of these are pretty benign. You can do a infusion of IV fluid to do forced diuresis to get 4 to 6 mils per minute promoted but you have to balance that with overload. So you want to make sure that they're not getting too electrolyte overloaded. So you don't want them to get pulmonary edema. So forced diuresis plus or minus. Once again, as the chlorphenoxy compounds are acids, their excretion can be really increased quickly by urine alkalization. So if you use sodium bicarbonate infusion for a urine pH of 7.6 to 8.8, that's forced alkaline diuresis, but it's critical to watch potassium because potassium gets driven intracellularly and you can wind up actually causing prolonged QTs and arrhythmias. Last resort, in a patient who's really, really, really sick, you can consider hemodialysis, but for the most part, they'll be okay. So these are the sources on your chlorphenoxy herbicides. Glufosinate ammonium. This is another herbicide that you find. And the mechanism of action in plants is it inhibits the glutamine synthetase enzyme, and it results in the accumulation of ammonia in the plant, as well as the accumulation of reactive oxygen species in the chloroplast of the plant, leading to oxidative injury to the plant. That's how it works. We don't have chloroplasts, so this pathway is not particularly significant for us. For people, you can have a little bit of enzyme inhibition that reduces GABA. And once again, we said GABA is the main inhibitory neurotransmitter in your brain. So if you don't have enough GABA, you can present with seizures. So mammals and humans, this is in big overdoses. So mammals and humans have, once again, different metabolic pathways to compensate for this inhibition. Significant poisonings have only been reported from oral suicidal ingestions, occasionally accidental, but mostly suicidal. Nearly 30% of these ingestions had resulted in no clinical signs, even if they were suicide attempts. The fatality rate in severe ingestion has been reported to be in a range of 6 and 18%. Neurologic complications will manifest with delay. So you need to watch these patients with big ingestions for 8 to 48 hours. There are occasional cases of respiratory failure with a 20 to 60 hour delay. There are scientific discussions as to whether the toxicity is actually due to the active ingredient, to the surfactant of the formulation. Remember that surfactant's part of is the soapy stuff. It's like detergent and can cause corrosive injury to the GI tract, or to the combination of both. In any case, an ingestion of 100 mils of undiluted formulation can cause really bad injury, mostly due to the corrosive nature as opposed to the active ingredient. So in general, once again, you can have neurologic symptoms and respiratory failure out as far as 60 hours. You can have some muscle weakness, irritation, and with the GI tract, once again, irritation, abdominal pain, nausea, vomiting, diarrhea. You can occasionally get bradycardia and hypotension if you've got a significant overdose. Metabolic acidosis and hyperammonemia, but once again, huge overdose to bypass the enzyme there. And in drowsiness and hyperthermia, you can have some seizures and convulsions. Once again, you're going to do regular, aggressive, supportive care for people who are sick. The vast majority aren't going to be sick. So contaminated skin should be washed with plenty of water and soap, irrigated with sufficient amount of waters, irrigate the eyes. Do not induce vomiting because, once again, the corrosive effect of undiluted formulations, if it coming back up the esophageal tract, you can hurt people. You can consider activated charcoal. I think in this case, it's going to be kind of messy. I'm not sure that I would do that so much. Once again, treatment is supportive. There's no antidote. If they seize, go ahead and give them benzos or phenobarb. There is some discussion about extracorporeal elimination, hemodialysis, hemofiltration, hemophoresis, but there are reports of severe neurologic signs under hemofiltration, even with decreasing glufosinate serum concentrations. Nobody's 100% sure why. So you want to be maybe careful with this. There's a single report of effective lipid emulsion therapy. So the same kind of lipid that you use for total parenteral nutrition, you can use that as a lipid sink to get chemistries that concentrate in fatty tissues and are hard to get into the blood compartment, so you can dialyze them. You can draw them in using lipid emulsion therapy. That would be totally experimental. That would not be my first line treatment. That's of academic interest to see if there's a benefit. The possible delayed onset of neurologic complications and severe intoxications results in should require inpatient observation for at least 48 hours. And here are your sources for this. Okay, glyphosate, and I'm sure there are going to be lots of questions about this. We're going to talk initially about glyphosate overdose, but if you have questions about glyphosate itself, I've got all sorts of information for you. So glyphosate is a herbicide of very low toxicity. It's got one of the lowest toxicities on the market. While it contains phosphorus, it is not an organophosphate like the organophosphate insecticides. Why is that important to know? Well, the reason why that's important to know is that the Lancet inadvertently mischaracterized in an article in 2015. It said that glyphosate is an organophosphate. And what that has led to is physicians administering escalating doses of atropine to patients because of this, because it's never been retracted from the Lancet. So it is not an organophosphate insecticide. You do not use atropine in these cases at all, because you can harm your patients. So it's marketed as a salt, but you can occasionally get a potassium salt, and we'll get into why that's important in a minute. But the way it works in plants is that it inhibits EPSP synthase, an enzyme in plants that interferes with amino acid synthesis, so aromatic amino acids. So if you remember, amino acids are the building blocks for proteins, and those proteins become the building blocks for your cells. In this case, EPSP winds up interfering with aromatic amino acids. So the plant stops growing because it can't make these aromatic amino acids. We don't have this mechanism in our tissues, in our cells. And so this does not affect us. There are some microorganisms that it affects, but for the most part, this is really, really not a pathway that has impacts in humans. So significant poisonings have only been reported from intentional or oral ingestion, while dermal contact and accidental ingestion cause only mild symptoms. In a large study of over 1,000 patients, only 5% of cases were moderate, severe, or fatal. So very, very low toxicity, even with ingestions. Ingestion of amounts more than 85 mils of formulation can cause serious poisoning, but it's very rare. It's very rare. More than 190 mils can be fatal, but you're not going to really necessarily know how many mils they drank. So guessing that's not going to be that helpful. Death can be due to respiratory failure, cardiogenic shock, or multi-organ failure. This is really probably due to the surfactant again, or the detergent. If they drink that, it's got corrosive effects on the esophagus, and that's where you tend to get more in trouble. There are scientific discussions about this as well. Okay, occasionally you can get a lactic acidosis. The GI tract, because of the corrosive nature of the surfactant, can cause irritation, dysphagia, abdominal pain, nausea, diarrhea, and very high doses, mucosal bleeding and hypovolemic shock. In very sick patients, you can get arrhythmias, hypotension. If they aspirate, they can get pulmonary edema. Renal and hepatic impairment really kind of only happens in very sick patients, and CNS symptoms are really an indicator of a severe course and potential fatality. Once again, you want to decontaminate the skin, wash them off. I would not have them vomit, because you're coming back up, right? You're with a corrosive formulation that can cause more damage. I probably wouldn't do gastric lavage either. Activated charcoal, you can consider it. Once again, it's going to be a mess. I don't think it's going to absorb nicely to the activated charcoal. The treatment is supportive. There's no antidote. Once again, seizures, that's a sign of marked toxicity. You want to control with benzodiazepines and phenobarbital. There may be some benefit to hemodialysis, hemofiltration for very severe ingestions, but this is very under discussion. Once again, a few reports of effective lipid emulsion therapy. I don't know that that's beneficial at all because glyphosate is hydrophilic, so it's not going to be in the fat. So I don't think it's going to have much of a benefit in this case. And these are the sources for glyphosate poisoning. Anticoagulant rodenticides. And we're going to review a couple. This has got a super interesting history. So for those who weren't here a couple weeks ago, I'm going to just really briefly go over it again. In the early 1920s, Wisconsin farmers, Wisconsin's a state in the northern United States, were faced with a very puzzling problem. Their cattle started dying of massive hemorrhages. In February of 1933, a farmer by the name of Ed Carlson got very tired of his cattle dying without an explanation. So he loaded a dead cow onto his truck with a bucket, along with a bucket of blood that would not coagulate, and brought them to the Wisconsin Alumni Research Foundation. There, they discovered that naturally occurring coumarin in sweet clover, so that's converted. That's in hay, right? In sweet clover is converted by mold in hay to dicoumarol. Dicoumarol inhibits vitamin K epoxide reductase, which in turn inhibits the gamma carboxylation of factors 2, 7, 9, and 10 in the liver. And that decreases prothrombin levels, causing anticoagulation. Warfarin was launched as a rodenticide in 1948. And you saw the rats in the previous picture. It turns out that rats are very particular about their feeding habits and warn other rats away from eating things that make them sick. Fortunately, warfarin doesn't make rats feel sick, so they eat it, and a couple of days later, they bump their heads and die. In a typical One Health fashion, remember we were talking about how physostigmine comes from the calabar bean, and that can be used as the carbamate. Insecticides can also be the same class of chemicals, not the same chemicals, but the same class of chemicals can be used as therapeutically. Well, the warfarin was no different. Researchers realized that there was a possible medicinal use for warfarin, and it turns out that people with atrial fibrillation greatly reduced their chances of stroke with anticoagulation. It was also thought that anticoagulation would prevent ischemic heart disease, which turns out probably not to be true with warfarin. With heparin can. After President Dwight Eisenhower had a myocardial infarction, he was put on warfarin to prevent worsening of his ischemic heart disease. Warfarin is still a first-line medication for the prevention of stroke, even though it started out as a rodenticide. So there are two types or generations of anticoagulant rodenticides. The warfarins, which require repeated doses, repeated ingestion to work, and then the so-called superwarfarins, which only require a single ingestion for rats, and they're stored in the liver, and they can cause long-lasting bleeding issues. In Kenya, only superwarfarins are still registered. So we're going to talk not so much about the warfarins as a rodenticide. We're going to talk about the superwarfarins. So once again, these depress vitamin K dependent blood clotting factors that are synthesized in the liver, 2, 7, 9, and 10. These factors have a relatively long half-life, so symptoms will usually appear a few days after ingestion. In fact, with warfarin, it also blocks activated protein C. And so because of that, in the first 3 days of administering warfarin, you can actually get procoagulant. So that's why in the first 3 days, you use heparin to make sure that they're not clotting. And then you eventually develop an anticoagulation effect. The antiprothrombin effect is used to diagnose and assess the severity of intoxication. This is done by measuring the International Normalized Ratio, or INR. That's a very common blood test that can be easily done in medical laboratories. A prolonged INR is associated with warfarin poisoning. Oral ingestion is the only route of exposure. In the vast majority of cases, this means a suicide attempt. These are pellets. These are often little kind of blue-colored pellets. And so I had a case where I had a patient who was psychotic and eating brodifacoum and eating it like candy. And the way he presented, nobody could figure out what was going on with him, because he was a schizophrenic. And he developed a foot drop. And when they imaged him to find out what the root of the foot drop was, they did an MRI and found a big psoas hematoma pressing on his the nerve bundle there, and wound up with a permanent foot drop. And then they were like, "How do you have a hematoma?" So they measured his INR, and then it turned out that he had been eating a super warfarin like candy. In some cases, toddlers can ingest a small dose of a grain or pellet, which is more often, it's really that those ingestions kids tend to be sometimes smarter than adults, and they spit it out. So you don't really tend to see bleeding in these cases. The amount of active ingredient in bait is very low, so a significant amount must be ingested to cause serious bleeding. And once again, if you've got it's very unusual to have inhalation and dermal intoxications, because you'd have to be in just a whole bunch of dust. So that's very, very rare. Okay, the super warfarins registered in Kenya are brodifacoum, bromdiolone, diphenthioline, and flucomethrin, all World Health Organization class 1A rodenticides. So they tend to bleed. People bleed when they get too much of this. So nose, mucous membranes, you get ecchymosis, you can get hematuria, a whole variety of bleeding. And what you really worry about in these cases is intracranial bleeding or hemorrhagic shock, GI bleeds. Once again, when you're getting this under control, you can get a paradoxical thrombosis if you overcorrect. So you want to watch the INR pretty closely. Only 2% of cases show any morbidity or mortality. The long-lasting effects are due to the strong binding of the enzyme, and the hepatic accumulation and high lipid solubility of these chemicals, and then enterohepatic circulation. So once again, you can decontaminate the patient. I would not induce vomiting because of the bleeding potential, and I would do repeat INR determinations. Sometimes you don't bump your INR at all if it's a small ingestion. INR determination for 36 to 48 hours after ingestion. That's what we do for kids, right? Because they're going to be procoagulant at first. They're not at risk of bleeding at first. I would get an INR in 36 to 48 hours. If the INR is normal, you don't need to do anything else after that. If the INR is elevated, you want to start administering vitamin K. And that's K1, not vitamin K3 or 4. And you may have to have them on vitamin K for a very long time because of the amount of time it takes these super warfarins to get out of the system. So if you have to give them, you may have to give them some prothrombin complex or recombinant factor 7A. And if they're bleeding, you may have to give them a transfusion. But vitamin K is the antidote. And these are your sources on the warfarins. Now, phosphides. These are really interesting as well. These tend to be fumigants, and you've got aluminum phosphide and zinc phosphide. And these come as pellets, and they will be often used in shipping cargo. So as a rodenticide. So what happens is they will load grain into a container and put this in the container, and when it comes in contact with moisture in the container, it releases phosphine gas. And what phosphine gas does is it goes and acts very much like cyanide on cytochrome C in the electron transport chain. And then you stop the production of ATP. So if you block this, you don't make any ATP. And it's essentially the same thing as suffocating your cells. If you imagine putting a pillow over your face and not being able to have respiration that way, this is on the cellular level what happens with phosphine gas. And so you will find there have been case reports of people who were stowaways on boats that got into one of these containers with lots of grain in them, and then when they opened the containers, they had died because of this kind of poisoning. So aluminum phosphide is a rodenticide and fumigant of very high toxicity, which acts by the liberation of phosphine gas and diphosphine upon contact with humidity or acids. The same is true for zinc phosphide, which is also used as a rodenticide. Phosphine, so if you've got these patients that get exposed to this, or they ingested in a suicidal ingestion, they will exhale this. So you do not want to be giving these patients mouth-to-mouth resuscitation, because you can inhale it and you can get sick that way. So it puts medical personnel at risk. So care, and in severe cases, you want to have a filtering mask is very advisable. There are anecdotal reports from Iran and India of self-ignition of exhaled diphosphine causing facial burns in patients. So you got to be careful there. The fatality rate of aluminum phosphide intoxications is high, 40 to 90%. While zinc phosphide ingestions are rarer, and you wind up seeing zinc in the GI tract, it can cause, you wind up getting emesis. The zinc stimulates emesis. There's no real antidote for this. The exact toxicologic mode of action is still under discussion, but it's really probably due to the inhibition of cytochrome C oxidase. Okay, so you get once again, if you can't make ATP, you're going to get a metabolic acidosis, and you're going to see lactate, right? Because you're going to go through your glycolysis to make ATP, and glycolysis can be anaerobic. And since it's anaerobic, you're going to go to a lactate. So you'll get a high lactate in these cases. You'll get irritation of the mucous membranes, ulceration. You can get retrosternal and epigastric pain because this is corrosive. Cough, dyspnea, chest tightness, pulmonary edema, respiratory failure, refractory hypotension, tachycardia. These patients are critically ill. If needed, contaminated skin, and you probably aren't going to get contaminated skin with this other than from the vomiting, right? And eyes must be flushed with ample amounts of water, but you want to be very careful because you don't want them to ingest any water, right? So you can put it on their skin, but you don't want it to go, you don't want to put it in their GI tract because that will increase the phosphine release. However, nearly all poisonings are ingested, so skin and eye contamination shouldn't delay treatment. Do not induce vomiting because that'll be corrosive. I would, once again, not lavage these patients because you're going to increase the phosphine concentrations that they're liberating. Some papers talk about lavaging with vegetable oil or castor oil. I don't think that's going to be probably beneficial. Okay, so treatment, you want to treat aggressive supportive care. Hypotension should be treated with crystalloid solutions. Colloid solutions might have benefit, but they can have serious side effects. These patients are routinely hypotensive and you will need vasopressors. You can give bicarb for the metabolic acidosis. Remember, the metabolic acidosis is really coming from the inhibition of the cytochrome deoxidase. So it's the lack of ATP production and the anaerobic production of ATP that's pointing you in that direction. And then cardiac dysfunction is difficult to treat. So sometimes you can do ECMO, intra-aortic balloon pump. These are not really useful or not available to rural hospitals. And a lot of these ingestions are, in agricultural settings. So it's very hard to get to that kind of level of care. And there are the sources for that part of the talk. And with that, I'm happy to answer any questions. Thank you for your attention, and asante.
Thank you, Doc. For a wonderful presentation, and right now I can see we have quite a number of questions on the our Q&A. So I would kindly request that we quickly go through them.
Sure. Yeah. So the dilute, what was the recommended dilution of hypochlorite sodium for washing skin? I think there's not a really a specific dilution that I'm aware of. We can look it up, but you just want to have dilute. It's just dilute Clorox solution. So if you put it in a fair amount of water, that should be fine. Why is magnesium sulfate not recommended nowadays? You know, a lot of it is because you don't need it. We used to throw all sorts of things at poisonings, and we realized that what we really need to do, that you had a much better survival with aggressive supportive care and not throwing all sorts of other stuff into that. Okay, and kindly share the slides to email. Yep, we'll do that. Datura stratonium is a pharmacologic phenomenon, but its biologically active components like scopolamine and hyoscyamine have psychoactive effects that cause hospitalization. Would you suggest its direct handling and usage as an antidote by people who have no background or in pharmacy? That's a great question. That's a great question. So Datura, that flower, can give you what we call an anticholinergic toxidrome. And the problem with anticholinergic toxidromes is that you block the effects of acetylcholine on your muscarinic receptors. So what does that do to you? What it does is it makes you have dilated pupils, so you have trouble seeing, a wildly agitated delirium. People tend to tear off their clothes and run around naked, and they wind up with heat stroke and seizures and things like that, because this intoxication can last for days. There's a case that the same consultant who had the malathion overdose told me the story about two young boys, 17-year-old teenagers, who took their girlfriends to the desert for a picnic, and they decided to drink some datura tea because they thought it would be a really fun way to hallucinate. And the girls were like, "We are not going to do that. That's very dumb." And the boys were like, "Well, you guys are no fun." And so they wound up making some datura tea, and then 15 minutes later, wildly hallucinating, stripped off all of their clothes and ran around having intimate relations with cacti. And so they had to come, an ambulance had to come get them. The girls were very, very impressed. And they were given physostigmine from the calabar bean as an antidote. And when they woke up, they were like, "Oh my gosh, how come we're naked? And how come we're full of cactus spines?" So you have to be careful with titrating the dose. But, you know, if I had somebody who was floridly cholinergic, that you could consider it. The trouble is they're vomiting so much that it might be hard to get it down in any meaningful fashion. But it's a great question. Okay, what's your input on aspiration pneumonia as resulting from a risk of gastric lavage? I am very hesitant to do gastric lavage in a lot of people. You protect the airway before you do gastric lavage, right? And so I'd be careful doing it. I would not do it if you aren't protecting the airway, especially in somebody who's got a lower level of consciousness. What's the role of milk ingestion in poisoning? Zero. I would not give milk to anybody in a poisoning. I think that people don't find benefit from it. How can someone induce vomiting for a conscious patient? You can induce vomiting with with ipecac. It used to be in ipecac, which also comes from a plant. It can make people vomit. But I don't know that it's that available. And so many of these things, if they're already vomiting, they're already decontaminating themselves. So I don't think you need to do that. please comment about the role of pesticides and insecticides in carcinogenesis. I will come right back to that question in just a second. Let me get through these because I've actually got a couple of slides that I can show you. The specific question that is on most people's minds is does glyphosate cause cancer? Roundup cause cancer? And the answer is no. And I will come back and show you the data on that. In terms of testing, pesticides are all undergo an incredible amount of regulatory testing to make sure that they will not do these things. I can't comment for the whole broad spectrum of pesticides out there, but I can tell you specifically about glyphosate, and I can tell you that people really try to make sure that they're not going to be carcinogens and that you're not going to get exposed in any meaningful way. Okay, that's a technical question. Let's see. In patients with organophosphate poisoning who've achieved atropinization but remain tachycardic above 140 to 150 for more than 20, is there a need to intervene? I don't worry about tachycardia in organophosphate poisoned patients. The tachycardia, I titrate atropine not to the heart rate, but to the pulmonary edema, because that's what's going to really kill them. I think that you can also sort of address what are the other things that may be making this patient tachycardic. Are they having pain? Are they hypotensive? Is it, and address those things, and that can maybe help the tachycardia. But I'd be a little careful. Especially in a young, healthy patient. I'm not so worried. They can sustain those heart rates, but I'm not so worried about. Start my video. Let's see. Can you see me? Oh, there we go. There we go. All right. Hi, everybody. Why can't we use DDT in Kenya to eradicate malaria? Yeah, I think that's a shame. I think that, well, it depends also. I think that there's some concern that there's some resistance, but it is an important way to eradicate malaria. There are a lot of other pesticides out there that can help do that. One of the advantages that the EU and the US have is that we have winter. So we're not in the tropics and we're not in the equator. So we don't have the same kind of pest pressure all year round. So it becomes harder to completely eradicate malaria and other insect-borne illnesses in places that have 24/7, 365 days a year, that kind of pest pressure. Okay, let's see. What are the risk factors, incidence, and prognosis of organophosphate-induced delayed neuropathy? The risk, the intermediate syndrome happens a lot, so I would expect it. Not always, but I would expect it. The incidence, I can't give you that number right off the top of my head. The prognosis is with supportive care, it tends to get better. The role of NAC and an aluminum phosphide, I'm not sure that there's a whole lot of benefit to N-acetylcysteine. Okay. 4-year-old. Oh, what antidote is required after a 4-year-old ingests pellets of rodenticide? So if that rodenticide is a superwarfarin, usually what you want to do is you want to check 36 to 48 hours later, because remember that it has to inhibit an enzyme. And that enzyme takes a while to turn off factors 2, 7, 9, and 10. And if you have a normal INR 36 to 48 hours later, you don't have to do anything. If you've got an increasing INR, then what I would do is start vitamin K and then follow vitamin K1 and then follow that patient. So there's that. Slides. Okay, recommended maintenance dose. On the slides, you can see the dose, and that's given to you. And once again, I would titrate it to pulmonary edema. Sometimes you'll find our patients don't know exactly product ingested. For example, liquid soaps made locally. How can we approach them? That's going to be often you don't necessarily need to know what the patient has ingested. You can sometimes tell from a toxidrome, like a organophosphate toxidrome, but often you can have just supportive care. So and you'll see, if you've seen through this talk, that there are not a lot of antidotes, right? We've talked a lot about supportive care, aggressive supportive care, decontamination, that kind of thing. So liquid soaps made locally, these soaps are going to have a little bit more of a corrosive effect, and then you're going to tend to see vomiting. So you may want to wind up, hydrating them, antiemetics, and making them feel better, kind of thing. Those kinds of things are what you're going to do in that case. Slides. What's the rule of NAC in ALF 3? Are you? Oh, is that aluminum? Oh, yes. What's the rule of N-acetylcysteine in aluminum phosphate? I don't know that there is a good rule for it. I think that that's going to all be experimental. I don't think it's going to be that helpful, because N-acetylcysteine is not going to help with the regeneration of cytochrome oxidase. So I don't think it's going to be beneficial. Have you thought about starting an emergency medicine fellowship in Kenya? I would love to start an emergency medicine fellowship in Kenya. I'd love to start. Yes, that'd be fun. I enjoyed that very much. Great lectures. Thank you. Very interesting. Thank you. Oh my gosh, I'm so flattered. I think I get everybody's questions. I think I answered everything. So unless there's anything else.
Yes, thank you, Dr. Lockwood. From our end here, our poison information, the contact center, we've noted that we've had quite a number of queries coming in from all over the country, but majority of them have been related to organophosphates, poisoning, maybe also people using them without proper PPE. And also we've had people raising concerns with the mosquito-treated nets that they are using, also affecting them.
Oh, the mosquito net.
Yes.
So the mosquito nets are often covered with a pyrethroid. So and what pyrethroids do is they block, so they modulate sodium channels in the nerves of insects. And so it paralyzes insects. People can get what you call a cold burn, and it's not a burn really. It's just a little paresthesia if they get when they come in contact with the mosquito net. That is not a sign of toxicity, and that will wear off. But that's a common complaint. If you get a little tingly skin, but I wouldn't be worried about that causing any long-term issue.
Okay, thank you, Doc. The other concern that I have from our hospital here in KNH, we've had quite a number of patients presenting with serious organophosphate poisoning, and especially for the attempted suicide cases. But when they show up, maybe it's even up to 3 days after, again, the availability of the pralidoxin is not always assured. But my question would be whether after 3 days, we still have a chance with pralidoxin.
It depends on the organophosphate. Different organophosphates have different times for aging. So it entirely depends on and I don't know all of that right off the top of my head. I'd have to look up which ones have which. But some organophosphates have to get metabolized. The parent compound isn't what the problem is. They have to get metabolized to another compound before they start exerting toxicity. So that takes time, so you do often have time to get to the enzyme. But pralidoxin though doesn't really work that well. And so you can have very mixed results with it. So that would not be my number one go-to. What I would really focus on is the atropinization of these patients.
All right, thank you. Maybe on the chat, I've seen a question, someone who had asked something outside the topic on how to handle kerosene poisoning in children, that is paraffin.
Oh, yeah. Okay. So the problem with kerosene, there's not a real antidote with that, but the problem with kerosene and lamp oils in general is that they have volatility. And so if a kid gets into them, you can wind up having aspiration of pneumonia, well, aspiration and then irritation and actual pulmonary injury because of the inhalational effects of this very volatile liquid. So it's going to be intensive supportive care. There's not an antidote, but yeah, those kids can get sick. They can get pretty significant pulmonary injury.
All right. I think at this point, I want to appreciate Dr. Lockwood for such a wonderful presentation, quite elaborate and educative. We are so grateful for having you and taking us through this. We hope to be having more of these as we go into the near future. And again, I want to appreciate each and every one of you who've logged in today, and you've been with us for just about 1.5 hours as we've gone through this presentation. At this point, I want to just say thank you. We are grateful. We may not be able to do this without your presence. Be blessed, everyone, and have a nice afternoon.
Thank you for having me. I've really enjoyed this.
Yes.